What I'm going to try and do is maybe just take you on a little journey from the point of impact of a spinal cord injury until the patient is back in home after acute care and rehabilitation. And we're going to maybe look at some things that we've learned through our spinal cord injury registry in Canada about both modifiable and non-modifiable things that affect the patient's outcome. And when I say outcome, I don't just mean an improvement in total motor score. Outcome involves reintegration into society, mental and physical component scores of outcome tools, functional ability. So I'll be trying to point out some aspects of outcome that are not just about motor score. So the Rick Hansen Spinal Cord Injury Registry, as I mentioned earlier, is pan-Canadian with data coming from 18 spinal cord injury specialized units and 13 rehabilitation units. And we know where patients get injured. So every spinal cord injury in Canada, the location of injury is known. And the importance of that is we can then look at the provision of care for those injuries and where best to provide that care, and whether proximity to a centre of specialised care for spinal cord injury actually makes a difference to outcome. So from an epidemiological point of view, in 2016 in Canada, the incidence of spinal cord injury traumatic was almost 2,000, with almost 3,000 documented non-traumatic spinal cord injuries. The average age, the median age was 47, mostly males, and 3/4 are incomplete injuries. We know that the median time for a patient with a traumatic spinal cord injury to reach a centre that's designated for the provision of spinal cord injury care is 5 hours. And about half the patients go directly to that unit, and then half go to an intermediary hospital before transfer to the specialised care. And why is that important? Well, we know that if it takes longer than 12 hours to get to a centre recognised and dedicated for spinal cord injury care, then your hazard ratio for in-hospital mortality is over 1.6. So you're far more likely to die in hospital if you don't get to a specialised centre early. We're able to look at variances within major cities. So if you look at Toronto versus Quebec City, in Toronto there are a number of centres that provide care for spinal cord injury. In Quebec City there's only one. And so patients will get to Quebec City Centre quicker and far more likely to get there directly than if they're injured in a city that has multiple centres providing spinal care or spinal cord injury care. If we look across all the patients with traumatic spinal cord injury, the median time spent in acute care is over 3 weeks. We found that 40% of our patients got surgery in less than 24 hours and almost nobody received steroids. And some of the outcomes or lessons that we learned was that surgery done under 24 hours gives about a 6-point improvement in motor score for incomplete injuries B, C, and D. And so that's why it's so important to look at outcomes other than just motor recovery or documentable motor recovery when you're looking at patients' long-term outcome. We found no impact of steroids to improve motor outcome, but the use of steroids did increase the incidence of acute care complications, and I'll touch on that again later. The overall in-hospital mortality is about 6%. And 77% of patients with a traumatic spinal cord injury will have a major acute care complication that will affect their length of stay. That's 77%. Sorry, a technological glitch. Here we go. So when we looked at the incidence of acute care complications and effect on long-term health-related quality of life, as I said, we found that 77% of patients had a major complication. The most common 5 were urinary tract infection, pneumonia, post-operative neuropathic pain, decubitus ulceration, and delirium. We were able to examine for risk factors for the development of each of those complications, looking at age or motor score on admission primarily as the risk factors. And we were able to see that there were linear relationships between, let's say, for example, motor score on admission and your risk of developing a urinary tract infection. So the more impactful or the greater your motor loss, then the higher your risk of urinary tract infection. And similarly, your higher risk for pneumonia, decubitus ulceration, and neuropathic pain. And the importance of this is to know that these acute care complications actually have a significant effect on length of stay. And so, as I mentioned earlier, if you can see, or if you can identify ones that are potentially modifiable, then you can affect that overall length of stay before transferring to rehabilitation. And interestingly, what we found is that it's only the occurrence of a decubitus ulceration in acute care that actually has a long-term effect on patients' outcome out to 2 years. Subsequent secondary complications such as fractures, depression, spasticity, they all affect the patient's long-term quality of life. But as far as acute care complications are concerned, the only ones that had any meaningful impact was the development of a pressure sore while in acute care. So when we look at the Canadian experience, 70% of patients go to a specialised rehabilitation facility after acute care. And if you do, you're 6 times more likely to return home. Whereas if you don't go to a specialised care for rehabilitation, your chances of going home are much smaller. The median time in rehabilitation is 76 days. And you see that most, let's say, if you go to a specialised rehabilitation centre, then you're much more likely to return home to independent living. Because of the numbers of patients that we've been able to accumulate over time, we're able to create hypothetical modelling to look at how a particular intervention or a new change in treatment might affect outcome. And with that modelling, for instance, this is one example, we're able to show that if you increase a patient's time spent with actual rehabilitation, so the more time they spend with a physiotherapist while they're in rehabilitation, then you can actually create cost savings because of the fact that patients will recover faster, they'll finish rehab sooner and get discharged home. When we look at the outcomes of patients with traumatic spinal cord injury and their community living, we found that 20% or 1/5 of patients who are injured while living in a rural community end up transferring to live in the city. And the belief was that patients moved from a rural community to the city in order to have access to more specialised care after rehabilitation. We found that if a patient has a spinal cord injury and has more medical comorbidities at the time of injury, then that has a significant impact on their outcome and may actually have more of an impact on their outcome than their total motor score on admission. Sorry. I'm talking faster than the button's moving. That's a bad thing.
Can you help with?
It's okay. And so we wanted to look at how does living in a rural community compare to that of urban, because a large number of our patients are injured in a rural community. And what we found striking in this is that when you look at patients who are injured in rural community versus urban, and particularly if you look at that, as I said, 1/5 of patients who, for various reasons, decide to move from the rural community to the city, they're more likely to become depressed after moving to the city. And if you look at all other outcomes, so whether that's physical component scores, their total FIM scores, they're similar for whether they stay in a rural community or not. And then their incidence of secondary complications such as autonomic dysreflexia, fractures, spasticity are all the same. The only thing that's different is that if patients move from the setting where they have family support, where they have a social structure, and they move to some place where they don't have that social structure, so moving from rural to city, they're more likely to become depressed in the long term. And that depression, as I'll show you in a second, is critically important to these patients as far as their satisfaction with life after their spinal cord injury. We looked at doing some stratification of the heterogeneity of spinal cord injury because the belief is that not all injuries are the same. And the lessons that we learned is that, that you have to look at far greater detail than just an A, B, C, D, or E. You actually have to look even further than just an anatomical level, but that the inability or maybe the confusion that often exists around the literature around whether timing to surgery makes a difference, whether steroids makes a difference, whatever, may be that we're not comparing apples to apples. And so each injury, based on either its anatomical location or its level of completeness, may be heterogeneously different from the other injuries, and so would require investigation of that particular subgroup. In our Canadian experience, we found that steroids made no difference to motor recovery, but actually increased your risk of an acute care complication. And when we looked at the influence of timing to surgery, as I mentioned earlier, we found that early surgery gains 6 Asian motor points in incomplete injuries. But it possibly reduces acute care length of stay. But obviously, if that's your only outcome that you're measuring, then you're not going to see a significant improvement in patient outcome with early surgery. Whereas if early surgery was to reduce acute care complications, then maybe that might have an effect both on acute care length of stay and cost, but also long term. We looked at the effect of a patient's age on decision making and access to care and outcomes after spinal cord injury. And what we found was that elderly patients in Canada are more likely to experience a delay in getting transferred to a specialised centre. They're more likely to experience a delay in getting access to surgery, and they're more likely to suffer acute care complications after their injury. And so they're very important things to understand about our provision of care to this elderly population with spinal cord injury, particularly if you reflect on some of the talks we heard earlier today about the oncoming tsunami of elderly patients and incomplete spinal cord injuries. We believe it's critically important to consider spinal cord injuries from a heterogeneity perspective as whether they're stable or unstable. Because when we look at the effect of stability, it has a significant effect on outcomes. So unstable fractures are typically in older people, usually fall from a standing height. They're usually incomplete cervical injuries. They're less likely to have surgery and have a higher motor score recovery. And so we really need to be better at discriminating the heterogeneity of the injuries in order to understand whether our interventions, whether the timing of our interventions have an effect, on outcome. This we found is a very important aspect of outcome in spinal cord injury, and that is the effect of health conditions or comorbidities on your outcome, and that maybe there's opportunities to optimize total or overall outcome of a patient with spinal cord injury by addressing modifiable health conditions. So we found that presence of health conditions in general in patients with spinal cord injury is associated with an increase in age, a more severe injury, higher BMI, unemployment. And we saw that functional independence of patients is lower in those who have multiple comorbidities or health conditions. And I draw your attention to the part in red. If a patient with a less severe spinal cord injury, such as an ASIA D, has 5 health conditions, then their long-term functional outcome may be no better than a patient with an ASIA C injury on initial admission. And so, again, speaking to the heterogeneity, if you're a sick, old, frail person with an incomplete spinal cord injury, albeit of a much better total motor score, you may actually fare far worse than a patient who has a more severe initial spinal cord injury from at least all the typical things that we measure it by, if that person has no comorbidities or other health conditions. And we found the lower FIM scores and essentially lower FIM scores and poorer long-term outcome in patients who had multiple medical comorbidities. And quality of life is poorer in those patients who have more health conditions, independent of the initial motor score that they present with secondary to their spinal cord injury. So minimizing health conditions may positively impact function, and so if we could find either manageable or modifiable health conditions, then that will provide an opportunity to make a significant impact on outcome, where we may not be able to have anything like that kind of impact on outcome if we're just trying to address motor score on admission and neurological recovery measured by the ASIA examination. If we look at the priorities of patients living with spinal cord injury, and I'll just move on here, that you see that there's a significant difference in what patients prioritize as important, whether that patient is tetraplegic or paraplegic, whether they're complete or incomplete. And understanding that obviously is critical for us to measure the right thing, because we might think we're measuring the right outcome, but that may not be important at all to the patient. And so understanding what the patient's perspective is critically important in ensuring that we measure the right outcomes. If you ask patients about the idea of a cure and a long-term cure for spinal cord injury, many of them say, yeah, well, you know what, maybe that's important, but what's more important is my neuropathic pain, my depression, my fatigue halfway through the day, my pressure sore that I can't get treated. And so patients are telling us that we need to focus on different outcomes other than getting those patients ambulatory, because that may in the long term not be the most important thing to that patient. I apologize if I'll just move quickly. And we see that despite having specialized centres for acute care, despite having specialized centres for rehabilitation care, we fall very short on providing adequate care for many of the aspects that patients deem important, particularly on their transfer into the community. So that's really a summary of some insights that we've gained, much of it coming from our registry type data, but much of it coming from interaction directly with patients and having them lead us. And I just wanted, I guess, to bring to your attention that there's far more important things, I would contend, to an outcome in a patient with a spinal cord injury other than just improving their total motor score. And I'd like to thank all my co-authors and fellow collaborators in Canada. Thank you.